This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from Nagoya University Hospital in Japan, recently published in the journal Medicine. It's a comparative investigation of the incidence of intraoperative seizures with Propofol and Remimazolam during anesthetic management for awake craniotomy.
This is a timely topic, Alara. For those of us in the OR, awake craniotomy, or AC, is the gold standard for maximizing tumor resection while preserving eloquent functions like language and motor skills. But as we all know, the awake part is a tightrope walk. Intraoperative seizures are one of our most serious complications.
Exactly. And while we've traditionally relied on Propofol and dexmedetomidine, there's been a lot of buzz lately about Remimazolam. It's an ultra-short-acting intravenous benzodiazepine anesthetic that was introduced in Japan around 2020. This study specifically looks at whether Remimazolam changes the risk profile for seizures compared to Propofol.
It's a retrospective propensity score matching study, which is an important detail for our residents and students listening. When you have a new drug like Remimazolam, your sample sizes are often smaller than the established standard, like Propofol. Ilara, walk us through the patient cohort.
Of course. The researchers reviewed data from 328 patients who underwent AC at their institution through September 2024. The inclusion criteria focused on patients with brain tumors in the frontal or temporal lobes requiring language tasks or focal resection for epilepsy near language areas. Initially, the groups were quite lopsided, 259 patients in the Propofol group, Group P, and only 69 in the Remimazolam group, Group R.
And that's where the propensity score matching comes in. To make a fair comparison of baseline characteristics, they matched them down to 49 patients in each group.
Right. They wanted to ensure that factors like age, tumor location, and medical history didn't skew the results. Before we get into the results, Dr. Aris, I think it's worth detailing the anesthetic protocol they used, because it follows the asleep, awake, asleep model, which is quite standard but has specific nuances here.
Yes, let's dive into that. For the Remimazolam group, they induced with a continuous infusion of Remimazolam benzoate at 12 milligrams per kg per hour, then reduced the dose after loss of consciousness. For the Propofol group, they used target-controlled infusion, or TCI, at a concentration of 3 micrograms per milliliter.
And maintenance?
Maintenance was Remimazolam at 0.5 to 1.0 milligrams per kg per hour, or Propofol at 2.5 to 4.5 micrograms per milliliter via TCI. Both groups also received remifentanil and fentanyl. They kept the bispectral index, the BIS monitor, between 40 and 60. They also used supraglottic airways like the iGel or ProSeal, which were removed once the patient regained consciousness for the awake phase.
I found it interesting that they were very proactive with anticonvulsants. They administered levetiracetam and phosphonephrine before the awakening phase to specifically prevent those intraoperative seizures we're discussing.
It's a robust protocol. They also used scalp blocks with ropivacaine to minimize pain, which is crucial because pain can be a trigger for agitation and potentially lower the seizure threshold. Now, let's get to the meat of the study, the seizure incidence.
Across the entire cohort of 328 patients, the overall seizure rate was 17.6%. That's 58 patients. Now, when they looked at the matched groups, 49 patients in Group P and 49 in Group R, the results were very telling. In the Propofol group, they had 10 seizure events. In the Remimazolam group, they had 13.
And the p-value?
The p-value was 1.00. Statistically, there was absolutely no significant difference in the frequency of seizures between Propofol and Remimazolam after matching.
That's a significant finding for us in the OR. There's often a concern that benzodiazepines, or the reversal of them, might complicate the seizure profile. But this study suggests that Remimazolam might not increase the risk of intraoperative seizures during AC compared to our traditional standby, Propofol.
They also performed a binary logistic regression analysis on the whole cohort to see what did correlate with seizures. While the type of anesthetic, Remimazolam versus Propofol, didn't show an association, one factor really stood out: age.
Younger age, right?
Exactly. Younger patients were significantly more likely to experience seizures during the procedure. The odds ratio was 0.95 with a 95% confidence interval of 0.935 to 0.983. Essentially, for every year younger a patient is, the risk increases slightly.
This matches what we often see clinically. Younger brains often have higher cortical excitability, especially when dealing with low-grade gliomas or focal cortical dysplasias. As a senior attending, when I see a 25-year-old on the schedule for a frontal lobe lesion, I'm already telling the team to have the cold ringer solution ready on the field.
Speaking of the field, the paper differentiates between partial seizures, facial or limb twitching, and generalized clonic seizures. Why is that distinction so critical for the residents listening?
Because a focal seizure can often be managed by simply irrigating the cortex with cold saline or pausing the stimulation, but a generalized clonic seizure is a crisis in an awake craniotomy. You're dealing with a patient whose head is fixed in pins, the dura is open, and they might lose their airway. It requires immediate pharmacologic termination and emergency airway management.
The study mentions that Remimazolam's ultra-short-acting nature is a benefit here. It has a rapid onset and offset. But there's also the flumazenil factor. In Group R, they used flumazenil as needed after the recovery of spontaneous breathing. There's always been a theoretical concern that flumazenil could induce seizures. What did the paper find there?
The authors noted that while flumazenil can theoretically induce seizures, there were no reports or evidence in this study, or really in AC literature yet, to suggest it was a primary driver of the seizures they observed. They used it to facilitate the awake phase, and the seizure incidence remained comparable to the Propofol group where no reversal was used.
So let's look at the why. Why might Remimazolam be performing as well as Propofol? The paper suggests that because Remimazolam is a GABA-A receptor agonist, it has inherent anticonvulsant properties, much like other benzodiazepines.
Right. Propofol also acts on GABA-A receptors. The fact that the seizure rates are similar suggests that the choice between these two specifically doesn't need to be dictated by seizure fear. Instead, we can look at other factors like hemodynamic stability. Remimazolam is often touted for having less cardiovascular depression than Propofol.
That's a great point. For our medical students, it's important to remember that during AC, we're not just worried about the brain, we're worried about the heart and lungs too. If Remimazolam offers a similar seizure profile but better blood pressure stability, it becomes a very attractive option.
However, we should talk about the limitations of this study. It is retrospective. And even with propensity score matching, the sample size in the Remimazolam group is still relatively small at 49 patients.
Agreed. The authors themselves point out that while the incidence was 20.4% in the Propofol group and 26.5% in the Remimazolam group after matching, the p-value of 1.00 indicates we need more data to see if a smaller difference exists that this study wasn't powered to find.
Also, let's look at the timing of the seizures. The paper notes that seizures can occur during the sleep phase, the awake phase, or during cortical stimulation.
They found that most seizures happen during the awake phase or during stimulation, which is what we'd expect. The anesthetic management, the sleep part, is designed to bring them safely to that point. The study's primary takeaway is that the choice of bridge, Propofol or Remimazolam, didn't seem to change the weather once the patient was awake.
One thing I want to highlight for the residents, the use of mannitol and antiemetics. The protocol used 150 to 300 milliliters of mannitol to reduce intracranial pressure and low-dose dexamethasone or granatosone for nausea. Why does that matter in a seizure discussion?
Well, nausea and intracranial pressure changes can lead to patient distress and physiological shifts that might complicate the clinical picture of a seizure or make an ongoing seizure harder to manage. Keeping the brain relaxed and the patient comfortable is foundational.
Exactly. It's all about the environment. If the brain is bulging because of high ICP, the surgeon is struggling, the patient is nauseous, your threshold for everything, including seizures, is compromised.
To summarize the data for our listeners, in the matched analysis, 10 patients in Group P had seizures and 13 in Group R had seizures. The odds ratio for Remimazolam as a risk factor was not significant, with a p-value of 0.18 in the regression. Younger age remained the only significant predictor with a p-value of less than 0.01.
So if you're a resident preparing for an AC case tomorrow, what's the clinical pearl here?
I'd say the pearl is that Remimazolam appears to be a safe alternative to Propofol for AC. It doesn't seem to provoke seizures any more than our current standards. But you should be doubly vigilant with your younger patients, regardless of which sedative you choose.
And for the attending surgeons, it gives us more flexibility. If you have a patient who might not tolerate the hemodynamic swing of Propofol, Remimazolam is a viable, safe option that won't necessarily increase the risk of a clonic seizure blowing your awake mapping.
The paper concludes by saying that Remimazolam may be safely used as an anesthetic for AC. It's a bold step forward in diversifying our anesthetic toolkit for these complex cases.
It certainly is. It's always good to see new pharmacotherapy being validated in the neurosurgical theater. Well, Alara, I think we've covered the key aspects of this study. It's a great example of how retrospective data, when handled with proper statistical tools like propensity score matching, can provide immediate clinical guidance.
Definitely. And for anyone interested in the specific dosages or the binary logistic regression tables, I highly recommend checking out the full paper in Medicine.
That's all for today's episode of the Neurosurgery Hub podcast. Thank you, Dr. Alara, for breaking down the data.
My pleasure, Dr. Aris.
And to our listeners, stay sharp, keep learning, and we'll see you in the OR.